Big data in healthcare is an emerging field where innovative technologies offer new ways to extract and reuse information from the available tsunami of data in diverse forms of text, images, different synthetic formats. The data is collected either by patients, healthcare organizations and healthcare professionals, but also healthcare equipment and technology, such as sensors and mobile phones. In the BigMedilytics project, the Erasmus universities studied the uptake of big data technology in healthcare. We interviewed external stakeholders on European, national and healthcare organizational levels. Additionally, we held interviews with pilot project leaders and group interviews with 12 project teams about their experiences. Based on this data, we developed causal models. A causal model is a visualization tool of how actors and factors influence each other. Causal models are helpful to understand how self-enforcing patterns can be broken and how we can change things. In this causal model, I will explain why the innovative nature of big data in healthcare is hindering its uptake. Big data technology in the healthcare sector is seen as risky by policymakers, healthcare managers and also the public. There are two reasons for this. The first is the media attention for data breaches and privacy issues. The second, many stakeholders lack knowledge about what big data entails. The common reaction of people is to avoid risk or to contain unwanted outcomes by asking for regulations, laws, norms, guidelines and policy. This calls for written rules that provide guidance on what is allowed and how big data technology should be performed. The development of these rules relate to the whole big data chain, starting from data collection, combining different data sets, data storage, analysis, developing an algorithm all the way until the eventual use of the algorithm for the benefit of the patient, the professional or the organization. The rules also focus on different topics such as privacy, security, safety, ethics and legal aspects. These diverse topics require different experts, such as a lawyer in the field of big data, privacy and security officers, medical ethical advisors, data protection officers or cybersecurity experts. New jobs emerge with their own language and perspectives on the rules that need to be set for big data in healthcare. These experts have different ideas of what should be seen as part of big data, as this is a fuzzy subject. For example, in the BigMedilytics project, some teams used e-health applications or medical devices for data collections. Experts argue that e-health and medical devices were big data, and thus the team had to comply to specific big data rules, which results in new approval of procedures. The variety of new experts who all focus on a particular subset of rules for big data results in project teams being confronted with a range of single opinions on what is allowed or not allowed. This is due to experts in different fields who are often not in close contact with each other, resulting in knowledge silos. As every knowledge silo is making their own rules, this results in big data project teams being confronted with what we call a swamp of rules. This is the misalignment between the different rules set by different expertises. The misalignment results in uncertainty in big data projects about which rules should be met before the project can start. This misalignment between rules is especially troublesome when data is shared beyond the borders of organizations or even countries. And whenever diverse experts in different organizations have another opinion on which rule matters and should be prioritized. We noticed in projects with data sharing across nations that differences popped up in the interpretation of the rules, despite attempts at legal harmonization such as the General Data Protection Regulation, GDPR. Moreover, next to European legislation, every country has different rules. Not only must big data projects comply with different rules, the rules are still developing rapidly. For instance, in one project, new national rules put the whole project on hold until the new privacy application was approved. In another project, the vendor of the data collecting device was sold to a company in a different country. This heavily influenced the progress of their project. We noticed that in general, the people involved in the BigMedilytics project find the rules cumbersome and they felt they were stuck in the swamp of rules. Healthcare professionals and data scientists needed advice on how to comply with the different rules, especially when the rules are contradictory or multi-interpretable. Yet, in some projects, the role of the experts was only checking the compliance with the rules of the big data practice. In this context, unintentional mistakes can happen. These unintended mistakes lead to much media attention, which influence the opinion of the public, and that, in return, confirm the idea that big data healthcare is risky. To find stepping stones in the swamp of rules, we observed 3 ways out. The first stepping stone was involving all experts as part of a project team. The experts were invited to share their ideas to solve the misalignment between the rules or other practical issues related to the set of rules. The second stepping stone were workarounds and elephant paths that the project team found to deal with rules as a form of knowledge brokering between the silos. For instance, in one of the pilots, patients were asked to give consent retrospectively for using their data. Physicians made home visits to explain their attempt. The third stepping stone was placing the project in a context in which learning by doing was allowed. The innovative nature of big data was no longer seen as risky, but the whole project as a way to learn how to avoid problems. Of course, with consent of all the stakeholders involved. Tying together the pieces result in a causal diagram, which depicts the opportunity to change the current, sometimes hindering aspects.